Today's topic is learning about the Exodontia. In this topic, mainly we are considering in last class we already studied about the local incision. So after local incision, we are going to how to extract the tooth. So what are the main learning outcomes? To appropriate forces is for the particular tooth, and also position of the operator and the patient, and the direction and displacement of the tooth during excision, and also what are the indications, contraindications, and how will you investigate the radiology and clinical features for the excisions, and the design of the microperiostral flap and the planned bone or tooth removal for the wound closure. So normally there are two types of the open method and closed method. So what are the flaws we use for the types of excision, and how will you manage the complications of exodontia. So, what is the definition of exodontia? It is defined as an ideal tooth extraction is the painless removal of all tooth or root with the minimal trauma to the investing tissue, so that the wound heals eventually and non-post-operative prosthetic problem is created. So, the main principle what they are telling is the pain relief, because if you get an adequate amount of anesthesia, then we become a painless removal of the tooth. So most of the time when you go for the extraction, there will be a maximum trauma will occur on the particular soft tissue bone everything. So we want to reduce the trauma of that area, that the soft tissue and also the access to the everything. And after that, the wound heals eventually. There will be no any healing problems, and there will be no any prosthetic problems will be created. So, what are the indications of extraction? Why we will accept the tooth? One, there is considered immediately any root caries, or we can never the poor prognosis of the tooth, like deep caries, everything. Then we go for the we can never manage the conservative and then go for extraction. Next one is the periodontal compressive. The patient is a periodontal problems like periodontal problems and grade 3 mobile tooth like that, no? Then grade 2, grade 1 like that, we will go for excision. Orthodontic reasons. Prosthetic mostly for the prosthetic rehabilitation. There will be any chance of the pathological lesions that also again leads to excite the tooth. And there is a non-other caries like erosions, abrasion, atresia, mainly due to the erosion. Abrasion already knows about the problems. So, what are the techniques used for the exodontia? One is closed, one is open method. Closed technique is also known as the simple technique or forces technique or intraoral. That means normal, you raise the flap using the forces and take out the tooth, that is called the closed method. When you go for open method, if you go try to use with the closed technique but the tooth broken and we can never take out the using with the closed technique, we have to open the soft tissue, that is called the opener. So while open technique is also known as surgical extraction or flap technique or transalveolar. They are called open method, transalveolar or flap technique. At that time we are using in open method, we are using the chisel bar, everything. So what are the principles of extraction? There are principles like the expansion of the socket. We can see the first diagram. We want to creating a space between the bone and the tooth, so then only the tooth can come out from the socket. So we are creating a space using with the extraction using the force, buccal, attraction, lingual, palatal, like that. We can creating a space, then only the tooth will come out. Second, the use of lever or fulcrum. The second diagram you can see one side there's a stone and the other side will be further. The that side that the load is there and other side the effort. So you want to the middle point, that is the fulcrum. There's the red point. So minimum effort, the maximum load. Next one, the insertion of the wedge. That means the beak will engage. That the diagram showing the beak will engage inside the tooth and the bone, so creating a space, and the tooth can come out. It's like a wedge pencil. So, what are the requirements for the successful outcome? The good for priority assessments. In the meantime, also, I already mentioned that indications. So, there will be absolute contraindications will be there for the exodoncia. One of the absolute contraindications is the uncontrolled diabetes, leukemia, renal failure, liver cirrhosis, cardiac failure. All these type of cases also we can never go for extraction. So mostly the diabetes, all this is the mainly problem that will create, and hypertension, uncontrolled hypertension, all these problems. So that is very important part for the extraction. So the requirements, the good pre-operative assessment like the history and the radiographs. So the first you will go for the proper history of the patient. Then you will go for the intraoral examination, the quick examination, all getting first of tissue and hard tissue assessment of the tooth reassigned. That's very important. And next one is the radiograph now. Then you check the periapical radiograph, provide the accurate and detailed information concerning the tooth and the roots and surrounding tissue. You can go for the occlusive radiograph. You can go for OPG. Normal IOP will take the first one. Then only we can go about the path of exit. The surgeon should look the caries of the extension of the root. Everything. So after this outcome, we can get an idea how the path of exit of the tooth, because sometimes if it's an angular tooth, sometimes the bone density is more and the root is dilated. The uh, path of exit will be different and go for sometimes closed method to transfer to the open method. So pre-operative assessment is very important part. And basic requirements for the successful is the first inform and reassuring the patient so that the stress and failures are minimized. Don't inform to the patient like it is a big surgery we are going to do like that. No, so that will lead to patient fear will be increased, and know the tooth anatomy well, which can be variable, and detailed clinical and radiography examination, preparation of the patient, and that means the correct position of the dental chair, and the position of the is very important. So, going for the maxillary tooth extraction. So maxillary tooth, the chair position, the angle between the dental chair and the horizontal floor must be approximately around 120 degree. You can see the first diagram is almost in an obtuse angle, 120 degree in angle, and the ocular surface of the maxillary tooth, you can see that it's 45 degree compared to the horizontal when the mouth is open. So then only we can see the tooth of the maxillary arch. The height of the dental should be 8 centimeter below the shoulder level of the operator. That is also very important. If you go for the mandibular extraction, the angle of the chair and the horizontal is about 110 degree. So the mandibular tooth extraction, the patient should be positioned in more the upright in position. The occlusal plane is parallel to the floor, and the chair should be 16 centimeter below the level of the operator's elbow. And already I mentioned the height of the dental chair for maxillary is 8 centimeter below the shoulder level. For mandibular, it's 16 centimeter below the elbows. Next one is that patient surgeon's position. For all the maxillary tooth and the anterior mandibular tooth and the teeth of the third quadrant, the dentist should be in front and the right, and to the left for the left-handed dentist of the patient. So that means you can see the first quadrant, second quadrant, third quadrant. First, second, third, you will stand in front of position. If it's a right-handed operator, he always stand in 8, 9 to 7 in position. If is going for the fourth quadrant extraction, the dent is positioned behind and to the right. That means almost the 11 o'clock in position. If the operator is a left-handed patient, he'll stand in front of the patient. That means the same like 9 to 7, but there is a one change will be there in the fourth quadrant and third quadrant. The left-hander will exit one first quadrant, second quadrant, fourth quadrant, stand in front of the patient, but third quadrant he will stand behind the patient. That is, he'll go to in 1 o'clock in position. So the extraction is accomplished in two stages. During the first stage, the tooth is separated from the soft tissue and surrounding it. During the second stage, the tooth is elevated from the socket using forces or an elevator. So, what are the forces uh, uh, before when you give after giving LA? So, we'll see what are the armamentarium needed for the extraction. First one is the periosteal elevator. The periosteal elevator is called the Mole's number 9. That is called the period. They have two surfaces. One is the broad surface and one is in the sharp surface. The broad surface normally using the bigger flap like that. The sharp surface they have a convex and a concave surface. Next one, this supporting the hand position. Mostly the right hand we are using the forces, the left hand will support and reflect the adjacent structures. That means the normally will support the going for the extraction of the tooth, will support the bone and reflect the soft tissue. So retract the tongue, cheeks, lips from the extraction site and improves the vision and stabilize the mandible. Because when you're going for the extraction of the mandible, we are giving that much force to the mandible, so that will lead to the dislocation of the TMJ. So that we can prevent to support the mandible is very important part when you're going for the extraction of the mandible compared to the maxilla. Maxilla will support the maxillary bone. So we could use flap elevation. I already mentioned the most number elevator number 9 is using the sharp surface, the concave surface towards the tooth and convex towards the gingiva. So always using the pen grasp and reflect both the buccal set and the palatal set. Using the label set and the lingual set reflects the periosteum from the bone and the tooth, then only we can engage the forces. The maximum if we can reflect, then only. Otherwise, what will happen? It will tear the gingival margin. So you can see how to raise the flap on the maxilla, how to raise the flap on the mandible. The same thing when you're going for raising the flap, keep that reflect the interdental papilla and always support the adjacent structure also. Otherwise, when you're using that much force, it will goes to the adjacent structure and creates too complicated. Next one, the expression forces. The forces always taking the appropriate forces you will take down. Then the first diagram, that means A, the figure H that's showing that is not the appropriate one. Always for using the forces according to the long axis of the tooth. So the first diagram, that is the wrong forces they took it out. Second diagram, they are showing the appropriate forces. Always keep it in mind, you take the appropriate forces and always engage with the long axis of the tooth. So the types of forces for the upper one, maxillary, lower one. root forces, pediatric forces are there. Upper forces there, shank, everything will be always same, and sometimes going to a not sometimes that we are going for the posterior little bended one. So that how can you differentiate with the upper one and the lower one? The lower one there will be a right angle one, and the upper one there will be big will be big and sharp will be always in the straight and little curvature will be there. The root forces, the difference between the root forces and the normal forces. The root forces the beak will be closed and the upper not the normal forces the beak will be little open, and pediatric forces is small in size compared to the adult one. So this is the forces for the upper central and the upper central lateral incisor and cannon forces. You can see the uh, forces will be in straight line, and this is what the normally using for the upper and central, lateral, and canine. Going to the premolar, you can see there is a slight curvature on the peaks and the shanks, so then only you can engage the forceps, and the beak will be little open, and you can engage the forceps upper long axis of the upper molar forces. There are forces that you can see. There will be, you can see the handle will be little bent, and beaks will be there is slight difference because one side the beak will be pointed and one will be flat one. Why they are using normally the upper molar have three roots, so the two roots there will be bifurcation is there, so the beak will engage with that bifurcation and flash forwards to the palatal side. So we can identify the forces which side the beak that is that quadrant. So if it's seen on the right side, that means it's on the left side. So that means second quadrant. If the beak is on the left side, that is on the first quadrant. Forces of the root, you can see that the beak will be close and little narrow one, so the beaks will engage to the root. So the normally they using bayonet forces and the normal root forceps. See the difference between the lower and rear force. You can see the beak towards downwards. That means in right angle. So no, normally, if any forces, the beak will go right angle, the handle, and that means that is the root, the lower forceps. Premolar forces, the beak will little open, and you can see there will be beak little broader one. So we can engage the force, and the roots will be conical in shape. Molar forces, the beaks, the both sides having the beak will be there. Beaks are sharp one, so there will be two furcation on the buccal side and the lingual side. See the diagram, you can see the beak will go down is that is the lower one, and the beak on the straight way that is on the for the upper one. Gripping the forces, normally the first diagram that we're using is the normal for British one we are using. The other one is called the American forces, so the grip will be little different from the British one. Application of the force of the blade. The as much the apical is possible, that means the engaging in the forces. You can see the diagram, the beak will engage the furcation, and a less accessible side of the first and reduce the risk of the fracture, because mostly if we never engage the maximum that will have what will happen, it will chance of the fracture of the tooth. So where the beak will be there, no, they will engage to the furcation area. So what are the techniques of the exertion? The sockets are dilated by applying the forces between the tooth and the alveolus, and maintain the apical and the sustained vertical pressure. Difficulty is more depending on the anatomy. So going for the upper anterior, that means upper central, lateral chestal canine. The roots are have conical roots, so the for you see the rotation is first rotation and the pull. Going for the premolar process, the roots are first premolar. Here I already know there will be two roots is there. So move backward and palatally. That means slight backward-palatal movement and mild rotation will give, because normally go for the alternations. They want to not try to do the root fracture. That's why minimum without fracturing we can do like that only. Going for the molar tooth legs 603 roots will be so give backward-palatal rotation. Going for the lower anterior tooth, first central lateral and canine single root flatness, so move labially and lift. Labiolingual traction and lift out. Going for the premolars, that's the conic roots, rotate and lift. Going for the molar, there will be two roots are there. Give, move buccally and that means buccolingual and figure of eight rotation and the, the displays of the root from the socket is the first one is the main firm, smooth and controlled pressure will give. Don't give a vigorous movement will do that will lead to the chance of the fracture of the tooth. This movement is applied the tongue from the hips and not from the elbow. So you will give the force from the uh, not from the elbow region. Mainly the wrist movement is very important part, but less important to the displacement of the tooth. Next one is the surgical exodontology that is called open method. Already mentioned the closed method is not a simple technique, forces, and the technique is called intraoral. Open method is called surgical extraction or the transoral extraction. Surgical extraction is the method by which the tooth is removed from its socket after creating a flap and removing part of the bone that surrounds the tooth. So that means if we want to raise the flap, then only we can go for the cutting, then only we can remove the bone. After that, then only we can take out the tooth. This technique is relatively simple and within the general practitioner. So if the basic principles of the surgical removal are followed. You can see the diagram here, they are using the handpiece, then only they can take out the root fragment after raising the flap. So the indications are the normal, depends upon the dilacerated tooth, and there will be anglers tooth like that. And the flaps is very important, but the proper vision is most important. Don't tear the soft tissue margins. And whenever we need, they give a osteotomy cut, that means buccal bone cutting, all these two. Then only we can take out the tooth. So the indication, first one is that the teeth of the maxillomandible that presents unusual tooth morphology, hypercementosis, dilaceration of the root tips, angulosis of the roots or with the abnormalities of the tooth morphology, impacted and semi-impacted tooth, teeth fused with the adjacent tooth, broken root tips that have remained in the alveolar bone, maxillary posterior those roots are including the maxillary sinus, roots with the theoretical lesions, deciduous molars whose roots influence the crown of the subjacent premolar. So these are the indications for the open method. What are the contraindications for the open method? There is a serious risk of serious local comma such that dislodging of the root tip into the maxillary sinus or injury to inferior nerve, mental nerve, or lingual nerve. Normally, the chances of the going for the extraction of maxillary, there will be a root fragment that will slip inside to the maxillary sinus. If going for the lower tooth, going for the third molar extraction, like then we going for open method, what will happen? It will damage the inferior nerve. And if you're going to raise the flap at that time, there will be high chance of the illegal nerve damage will be there. If there is a serious medical risk present, then we high chance of medical compromise, don't do it. And large part of the alveolar process needs to be removed because when you go for open method, there will be maximum amount of bone removal will do. Then only we can take out the root fragments from the socket. So what are the steps for the surgical procedure? The surgical procedure for the excision is impacted to includes the following like incision and reflection of the mucopelluceal flap. That means for the incision and reflection of the mucopelluceal flap, then only we can get the accessibility of the surgical area. Removal of the bone to expose the impacted tooth. That will do using with the chisel or bar. Then luxation of the tooth and care of the post-surgical socket and suturing the wood. That means after the luxation of tooth, will take it out and the post-surgical socket will get take care of using with the irrigation and suturing without gapping. Will do a tight closure of the wound. You can see the incision is placed only in the dental papilla and reflect the make the very safe. After that, the removal of the bone, normally using with the bone roger, burr, or chisel. The bone roger, normally using the bony speakers, or using burr and chisel. All the techniques they use, sometimes they will use. Normally using the burrs. Then, after raising the flap, then they using the bone cutting will do on the buccal side. If it's impacted, you can see on the second diagram that the buccal bone cutting on surrounding the tooth they will do. And sometimes we want to division that is called odontectomy. We'll section the tooth into two, and we cut into two, and we'll take out the that part. Then after the section, then to take out, and that will check it out. There will be any bony spicule or anything will be there. Then we'll trim it using with the bone file, removal of the debris, and cleansing the accession site with the saline, betadine with saline irrigation. We normally use to irrigate the socket. And suturing of the wound. Suturing, there are different types of suturing. We'll do it because normal the insertion to socket in the books they mention using the figure of 8, but normally using is that symbol interpret switch is the horizontal mattress switch, the vertical mattress, then uh, continuous switcher, continuous slope switcher. All these type of switchings are there, but normally using the symbol interpreter switcher. And the type of material, there are absorbed and non-absorbed materials are used for the suturing. Uh, the most thing is the post extension care that is related with this saline and remove this tissue tags and granulation tissue from the soft tissue of the site. Compress the annular bone with the finger pressure. That is very important. After extraction, we will go for finger pressure. Will do on the annular bone. And suturing if the papilla is burning extraction and they across the middle of the site. And to stop the bleeding, use the post pack covering the socket and instruct the patient to apply gentle and continuous pressure by biting on the gauze for at least of 30 minutes. After 30 minutes, take out the gauze slowly, don't spit out or suck, and it promotes the bleeding. If the bleeding runs out, comatose, the patient asks the patient to take a cold wet gauze bag or tea bag over the area quite firmly for the 30 minutes. Avoid rubbing the areas with your tongue. Do not walk for 24 hours, and it may that leads to interfere the healing. Don't rinse or brush for the tooth for around 12 hours. These are the main things we will do, and the normal if it's going for open definitely will give the anti-inflammatory and antibiotic also will give avoid hot food. for the first 24 hours. You can take water or fresh juice. We can don't take that fizzy drinks. And I would advise you take the soft diet. These are the most common things you will do after the open method and the closed method techniques. This is only we discussed with the exponential part. Next only we will go for the complications of the exponential. Thank you.